Ray.
Yeah.
Responding to a 73-year-old male to a home residence. Call comes in as shortness of breath and weakness.
73-year-old from home. Just grab a...
Do you need papers?
Yeah.
You can use mine. Why don't you just use mine? Right on the back.
Alright, BSI has been safe. I'm assuming I have one patient.
One patient.
Consider cervical.
I'm going to say no trauma.
No trauma. And for additional resources if
Yeah,
need be.
everyone here, everyone is ALS.
Alright, so as I walk in the room, how do I find my patient?
We found a 73-year-old male. He is sitting in a tripod position. It looks like he has a hard time breathing.
Alright, so as I approach my patient, I see acknowledge my presence.
Yeah, he looks at you and says hello.
Alright, so I told him that I'll tell him EMS, tell him my name, ask him what's going on today.
He says, you know what, I woke up this morning, I felt weak, I vomited twice, and I'm feeling it's hard for me to breathe.
Okay. So he's alert, he tells me what's going on, I just want to gauge the mental status.
Right.
So I'm saying he's like times 3.
How do you know that?
He tells me the events, he tells me, what's his name.
Did he tell you his name?
Yeah, no, what's his name?
This is Mark.
Alright, so Mark knows where he is and he knows what's going on. Alright, so he has talked to me, he has a pattern airway. From the looks of his breathing, how's his rate and quality of his breathing?
We're going to say he is breathing at a rate of 26.
Alright.
He has good tidal volume, but you do see accessory muscles.
Do I know any like JVD or check deviation?
Not present.
Alrighty. I'm going to put my patient on a non-rebreather at 15 liters per minute, and I'm going to assess for lung sounds.
Good.
Like, yeah.
You want to reverse that? Or put them on the...
Well, I mean,
I would say listen to your partners.
hey, so let's just put him on a, let's get a saturation.
Saturation reaches 89%.
89% on room air.
Room air.
Alright, so put him on non-rebreather here. Checking his lung sounds, do I
We'll say lung sounds up clear.
I'll clear all fields. Alright, what's his CTC?
Right now we're going to say he looks diaphoretic as a tremulous look appear cold.
Okay, does he have peripheral pulses?
He does have pulses.
What's his rate and quality of those?
We're going to say the rate is, let's say roughly 70 and it's regular.
70 and 70. Okay. Alrighty. Do I notice like any central cyanosis or any clubbing of the fingers?
No cyanosis, no clubbing noted.
Alright, so high priority. I'm going to, does he have any past medical history?
He says, yeah, he has a history of diabetes and high blood pressure.
Okay, what's his medicine that he takes?
He takes insulin, he takes Captopril, and he has 81 milligrams as per daily.
Okay. So he's just weak and vomiting, right?
Yeah.
And shortness of breath. Any chest pain?
He says no.
Okay. While I'm asking all these questions, will be asking a lot of these questions. Let me get an IV access. Let me get a blood pressure, heart rate. Let me see how he's doing on the SpO2 on the supplemental O2, and let's put him on a 3 lead.
Okay. Blood pressure is 98/72. Heart rate is 72. Respiratory rate is 26. Saturation with non-rebreather mask went up to 95%.
Do you want a sugar?
95. Yeah, he's diabetic. Let's get the sugar.
120 milligrams per deciliter.
All right. So past medical history, diabetes, hypertension. Any allergies to food or meds?
I have no allergies.
Okay. Any surgical history? Any change in medicine? Recent hospitalizations? Any drugs, alcohol?
No hospitalization recently. No changes to my medication.
Okay. All right. You said you woke up this morning. That's when it started.
Yeah, I felt very weak and I vomited twice.
Okay. Any blood in the vomitus?
No blood.
Any no recent illnesses at all? Have you ever felt this way before?
No, this is the first time.
Okay, what was your last oral intake?
I actually had dinner last night. That's the only thing I ate. Didn't eat anything this morning because I felt nauseous and I vomited.
Alright,
Don't want some PVC.
alright, cool. You feel like generalized body weakness or weakness on one side?
No, general weakness. It's hard for me to even get up from this bed.
Alright, so let's see what my monitor got for me then. Alright, so looks like a sinus rhythm with, yeah, PVCs. Alright, let's get a 12 here then.
The one that's the top.
I got an IV access on it, right?
The EKG all the time.
So he has elevation in V2, V3, so anterior wall, sinus rhythm and anterior. What do you think? No allergies, right?
No allergies.
Alright, cool. This sort of thing ever happened to him before?
He says he denies. He says no.
Alright. Nice. Yeah, subtle, alright. So he's on O2. I might hit transmit on that because he's showing a anterior wall, MI. No chest pain.
No chest.
Alright, I'm gonna put him on 224 aspirin.
How much?
Is 224? Yeah,
Yeah,
224 aspirin PL. Alright.
Give it a 1053.
And
Yo, all our watches are different. It's driving me crazy.
That's yours.
Mine says 1058.
alright, is his blood pressure still the same? 9872?
My
His
phone.
blood pressure is still the same.
Alright. Alright, so I look on my monitor now. I see there's a change. Is my patient still responsive to me?
Still responding.
Alright, so
Still talking.
he's talking?
Yeah.
Okay, so he's showing VTAC with a pulse. Alright, guys. He's talking. Let's sedate him. You think we should sedate him and then
Get a
run
pressure.
shots?
Get a pressure.
Get a vital spread.
Well, that's a lethal rhythm.
But you
But
gotta
it
get
could
a
be
pressure.
stable. You have to determine if it's stable or unstable.
Exactly.
Alright, let's VTAC with a pulse.
Yeah.
Alright?
Yeah, but he's mentated, so you got a blood pressure.
Because if you're stable, you
Alright,
can-
let's get a blood pressure and just draw up one, actually 100 milligram of lidocaine,
Blood pressure 9672.
9672.
He's still talking.
It's 1
Let's go with our
milligram per kilogram.
antiarrhythmics, alright?
Okay.
Go with our antiarrhythmics. Let's go with
Lidocaine or Amiab?
let's go with lidocaine.
Okay, it's 1 milligram.
Do 100 milligram in
How much does the patient
It's
weigh?
maximum
weighs
100.
100
Yeah.
100 milligrams
Alright,
and
100 kilograms.
100 cc.
100 kilograms. Write down his weight.
100 kilograms.
Yeah.
So what drug do you ask for?
Lidocaine,
How much
100 milligrams.
and how it's going to be given?
Yeah, over 2 minutes.
In what volume?
In 100 cc of saline.
I'm sure about that.
It's 10 cc.
10 milliliters normal saline?
cc?
It's
Where are your protocols?
1 milligram per kilogram IV over 2 minutes.
yeah.
Slow push?
So,
You take the lidocaine.
Back to the
This is 5 mL each milligrams.
Does it say how many milligrams?
100.
Yeah, there you go.
20 milligrams per ml. 5 mL over 2.
So it says over how much time frame? Over 2 minutes.
It's too late to well, if this doesn't work, you can always use the amio.
Yeah.
So the amio is going to be 150 in D5W
Why it needs to be pushed out?
if we do have to do it.
You notice your patient is not responding to.
Alright, does he still have pulse?
Who's checking the pulse?
Francis Mike, I was doing it on left.
No pulse. No palpable pulse.
If we start CPR, and I'm gonna call for like hands.
Start back at the
One monitor.
Wait, what was the time that he got?
11.
11? Alright, so CPR, we got the pet.
Get ready to shot.
CPR is going, ventilate the patient. He does not have a pulse, so this is VTAC, no pulse, so I'm going to defibrillate to my maximum joules. Set up and keep doing CPR, good quality. Alright, everybody's clear? Alright, we're gonna shock. Alright, continue CPR. We're gonna recheck every 2 minutes. 7, 8, 9, that's like 9:40.
9:45.
So 9:45, recheck, we're gonna recheck the rhythm, recheck the status. While you're ventilating, I want this guy intubated.
Another cycle.
Do another rhythm check.
Another rhythm check, and then
You want an epi?
yeah, push out 100 milligram, not 100
Or that's
milligram,
epi.
1 milligram of epi, 1 to 10,000.
Epi's moving at 11:02.
11:02. And just 11:02, right? Okay. So we're gonna recheck this status at 9:45. That's our next rhythm check. While he's doing that, we got yeah, let's see. Yeah, let's check our H's and see. I mean, he is diabetic, hypertension. His BGL is fine.
Going somewhere?
What medication is he on?
Captopril, aspirin.
I think aspirin. I think
Insulin, captopril, and
Alright, at 45 we'll recheck.
right?
Do another antiarrhythmic.
Hold on 1 second. As soon as you charge him, as soon as you shock, alright, everybody's good?
So what we're gonna
Alright,
do,
continue
right?
CPR.
Second time, right? Before we give the shock, right? We always wanna confirm
pulse
the
check
pulse.
first.
Yeah.
Always,
Check
always,
the
right?
pulse.
Even though I know this is refib, right? But the other rhythm was VTAC, so
Yeah.
very important to check pulses before you defibrillate.
Got it.
Alright.
Continue on
Oh,
CPR.
let's switch.
And
You gotta push.
just draw up 300 of amio. Give an IV push.
Alright, so you guys were talking H's and T's. What do you think was the cause of the cardiac arrest?
And we'll do 1 milligram of epi.
Want the ammo first?
Let's do the epi first, and then do the amio. Yeah. $9:45. That's what, 10:45 now. 11:45. Get them checked.
So out of the H's and T's, what do you think was the cause of his cardiac arrest?
Diabetes, hypertension,
What's your 12-week shot?
trauma.
What's your 12-week shot?
Oh, it's thrombosis.
Yeah, thrombus.
Where?
And tibial wall.
Coronary thrombus, right?
Yeah.
This is always facing towards the mouth.
Nine, 10. Alright, the rhythm check.
Watch, they're charged. I'll continue, and then once it's charged, I'll do rhythm check.
Alright, cancel that. Let's check for a pulse.
Pulse is present.
Alright, cancel this.
Sun button is at the bottom.
This arm. Alright, he has a pulse. Let me get a 12 lead.
Okay. The same 12 lead that you had.
Alright, 12 lead. Let me get a vitals, SpO2, capnography.
Responsiveness.
Oh, sir, can you please squeeze my hands for me?
He does. He squeezes your hands.
Oh,
He starts to reach with his arm for the ET tube.
oh, alright, guys, just like hold him down. We're gonna sedate him.
Blood pressure comes back 96 over 70.
Alright, we're gonna hit him with ketamine. I think it's 1 milligram per kilo. No,
Wait,
2
let's
milligram per
Before you
kilogram.
give them that.
Let's look at. Do we have?
I'm pretty
I
sure.
don't think we have ketamine.
I think it's 1
We have
milligram.
Yeah,
Yeah.
You have no narcotics in the
Yeah,
drugs.
so what do you?
1 milligram per kilogram, max of 100.
For area management, we get 1 milligram per kilogram, max of 100.
Alright, let's hit him with ketamine. Because the ketamine won't affect the blood pressure.
Oh, we're not that.
Yeah, you're not gonna
Because
have
it's
ketamine.
controlled. Yeah.
But tell me why you chose this drug.
Because he's hypertensive. What's his blood pressure right now?
96 over 70.
He's still hypertensive, and if I give him like any of my benzos, it's gonna tank the blood pressure even more, and he's probably going to back into arrest. So ketamine is gonna really affect the
Yeah,
blood pressure.
but what are we trying to do with this drug, right? So he's reaching for the tube, so he's
Yeah.
feeling what? He's feeling pain, right?
Uh-huh.
So what drug probably you have that? Yeah, fentanyl, right?
Fentanyl.
So he
yeah.
doesn't, yeah.
Yeah. Why
Does it-
fentanyl? Because it has,
It's
The
it doesn't
energy,
affect
yeah.
the blood pressure.
and it also has analgesic
Yeah.
properties, right?
Mm.
So we want to get, and then we can also offer sedation. So we want both sedation and analgesic for this effect, right? And we want the patient to be comfortable, right? We're not going to be restraining his arms for the entire duration, right?
Yeah.
So I would say fentanyl would probably be a better choice, right? So the dose, how much would you ask for? I would say 1 mic per kilogram.
So it's 100 kilograms. 100. 100 micrograms.
Would you give both or just fentanyl?
I would just give fentanyl, right? Because usually someone who's having pain secondary to the tube,
Yeah.
that will be enough to give me analgesic properties, right? So we got that. What else we doing post-ROSC?
We got totally.
12 lead was showing elevations
We
where?
got responsiveness.
Elevation and to
Okay.
so
Just tell them which one.
so transmit.
Okay, so let's say you transmit, they give you authorization to take them to the cath lab.
All right, back to my patient. I walk in.
You ready to give me a report?
Okay, let me just tell my patient real quick.
Before,
Yeah.
everyone.
Alright.
And don't forget, we gave 300 of amnio.
You have the template, yeah.
Yeah, horrible time with documentation. All right.
Do you want to write down your
Bad time management. Anyway, alright. Walk in. I have a 72-year-old male with a history with a current. Well, I walk in the room. I'm gonna say I have a STEMI post-arrest.
Okay.
Alright. I give them my EKG.
You got
I'll tell them that I have a 72-year-old male with a history of hypertension and diabetes. He got today because he was feeling generalized weakness and feeling nauseous, vomiting. Forgot how long, but like upon like waking up.
Okay.
No chest pain, feeling the shortness of breath.
Yeah, I like your report. It's
Yeah.
very,
Yeah.
lot
This,
of-
this is what it's like in real life too.
yeah.
What? Alright,
Your
so you had any cardiac? Yeah, that.
I know you guys, the moment you don't know what to talk about, you revert back. Okay, we gave 3 shots, we gave 7 nappies, right now blood pressures. Right, so the point being, right, like, so as I was trying to explain to you, right, I gave you the template, right?
Yeah.
Think of it like this, right? You're bringing somebody to the cath lab, right, or to the ER, to the resus area. They're thinking, what's the next actionable step they need to take, right, on their end, right? How many EPIs and all that is great, but it's not going to help them, right?
I'm
So-
trying not to say like we give like epi, we shock them to
Yeah,
bodies.
that's what you don't want to say. So I'm glad you realize, right, where you want to have fix your your stuff, right? So timekeeping and reporting, right? So the way I would start is this, right? So it's not 72, it's 73-year-old male
Yeah.
with who has a pertinent history of diabetes and hypertension. So diabetes, hypertension, that's risk factors,
Yeah.
right? Who presents with, we didn't get the time, but you want to say presents with duration, right, of let's say 3 hours of weakness, right, shortness of breath, and vomiting, right? Now we know because he's diabetic, he's going to have atypical presentation,
Yeah.
right? So he may not complain of chest pain, right? And then your subsequent thing has to elaborate on is history of present illness and his chief complaint, right? Specifically for cardiac would be OPQ or STI. So onset, provocation, right? If there's any radiation, severity, time, any intervention. So you could have elaborate. If he's not complaining of chest pain, you could have say, okay, how do you feel? What's going on? Okay, I feel short of breath. Tell me, right? Can you describe it for me, right? When did this start? What were you doing, right? When this began? Does anything make it better or worse, right? And when you have the pertinent information, you relay that. Then you want to, in your report, you want to also say, right, is his condition improving? Is it the same, right? What's going on, right? So, and why did he call 911, right? What's changed that he called 911? It's very important to know. So, like, you'll say, okay, what's different is this episode is like nothing else I have ever felt before. I feel very weak. I vomited. I feel short of breath. And since this began, it's not improving, right? So now we know that, right? And then once you give all this pertinence, then you want to also inform them of his allergies, the medications he's on, right? And then you could state your vital signs, current vital signs, and then your other interventions you have performed, right? So very important, right, when you are actively doing this, record your stuff. Record your stuff so that you have time frames, right? Not only of when you gave your medications, when you got ROSC, when the patient was cardiac arrest, but also the demographics, right? So the reason why you need the front end is what you need to tell this to the ED or the cath lab for them what to do next. The reason why you need the times is that when you're going to document your ACR, when the patient went cardiac arrest, what time you put your tube in, what time you gave your epi, what time you gave your amio, how many shots you gave, what times. Make sense? And they have to be in accordance with the protocols, meaning like you don't just shock every minute, right? We do it every 2 minutes, we reassess, right? And the other thing I noticed, we did not really check the pulse when we delivered the shots, right? So the first rhythm was VTAC. VTAC can have a pulse. So it's important to check a pulse before you shock. VFib, most likely you're not going to have a pulse, but it's still important to check a pulse when you're doing the any electrical therapy, right? So it's very important. I would say my advice for you would be have a good record keeping. So you're recording, right? You're not gonna have a recorder in your ambulance. You're the recorder, right? And then write a concise report using the format so that you're not all over the place. Do not start telling me how many EPIs you gave, how many shocks you gave, and all that because that's not important information right now. Make sense?
Yeah, true.
Okay. You guys have any questions? Right. So just to set it. You can take a picture of that.
Yeah, I think this was like this is kind of like one of the hardest.
Yeah. It's not that it's hard. You just have to implement. You just have to put a lot of things together. The other thing is, right, You guys talking about H's and T's, right? But the idea here is you're listing them, right? If it does not apply, right, don't keep going back to it, right? He's diabetic, but sugar was fine, right? He was alert, right? Probably not. But we have a 12 lead that showed elevations, right? Anterior wall, probably coronary thrombus. So go through your H's and T's. Maybe you have if you have the ACLS book, they have like a little pamphlets that it comes with. You could pull it out and it has all the H's and T's. So go one by one. Hypothermia, right? Hydrogen acidosis, hypokalemia, right? Go through all of them one by one, right? Thrombosis, trauma, toxins. Go through it, right? And then see what you got. If that doesn't apply, go to the next one, right? Sometimes you will say, right, like, okay, we're at hypoxia. Do we still have hypoxia? No, we intubated. We're giving him HyCon O2, right? Rule out hypoxia. Hypoglycemia, no, sugar is 120, right? Rule that out. Hypokalemia, right? Any history of dialysis? Is he getting dialysis? No, right? Probably not. So go through it, right? You guys have any questions? All right.